psychiatric mental health nursing. So now we're getting into the diagnosis and supportive information testing different psychiatric mental health diagnoses. And it's much more interesting, at least I think. So hopefully it goes a different tone. And I hope you see some of these things in the psychiatric clinical setting. I hope you don't experience it like to your face, but you'll see it. So anger. So anger and aggression are definitely different. So anger is a normal human emotion. So anger is an emotion. So you can express it assertively. And if it's channeled correctly, it can actually be a positive motivating factor. And so when you look at anger, it becomes a problem when it's not expressed, and when it's expressed aggressively. And so that's where aggression comes into play. A lot of times people combine anger and aggression together, and that's where it gets the negative connotation. And you have violence that occurs when individuals lose control of their anger. So we've all experienced anger in some form. Most of us experience it from mild irritation, but it can go all the way up to intense fury and rage. And so when you look at these physiological and biological changes that happen, you look at increases in blood pressure, heart rate, and hormonal changes. What's that triggering if you reflect on med-surg? Pardon me? And which system is that part of? The sympathetic nervous system, correct. So taken from the book, again, it's not a primary emotion, and it's learned behavior. So who do you think influences our anger the most? Where do we learn our behavior from? Our parents. So people that are either in our primary household or people that we're closely around. So it can be by people that are in close relatives or also close friends. And it can also be influenced by television, radio, and our societal and cultural influences that we can be heavily immersed in. There's also been meta-analyses done that show that socioeconomic factors have a large part to play in anger and aggression development. So practice question, a client has not received what was expected for lunch and directs an angry verbal outburst at the nurse. Which is an accurate description of this display of emotion? Anger is a primary emotion that is automatically experienced. Anger is a psychological arousal, Expression of anger can come under personal control. And expression of anger and aggression are closely related. Yep. Expression of anger can come under personal control. It is a learned behavior. We know that the expression of anger is learned. The expression of anger can come under personal control. So, like I said at the beginning, anger often takes on a negative connotation. And society often links anger and aggression together. The difference is we know that anger is a learned emotion, and then aggression is the way an individual expresses anger. So we have anger as a learned emotion, and then aggression as an expression of anger. And if you start looking at the characteristics, aggression, there's an intent to harm individuals. and this is often obviously done, can be intense verbal aggression, then you've got, the physical assaults with fists, weapons. But there's that punishing aspect that comes into play. So when you look at anger and aggression, and how this occurs and how this develops, the predisposing factors, modeling plays a huge role. So we said that it's a learned behavior, and so role modeling comes into play. And so you look at role models as being positive or negative, and so we've all had role models in our life, correct? And they all take a positive or negative form. When we talked about values, beliefs, and attitudes, and so this can shape people that we look up to. Like we said, our earliest role models can be the primary caregivers, and that's all we have exposure to. The role models are obviously not always in the home. We start to, as our attitudes and beliefs develop, we start to branch out and we have other role models. Like I mentioned earlier, evidence support, the role of social media, video, television, as predisposing factors to aggressive behavior. And so when you look at socioeconomic factors and people that view drug use, substance use, other trauma-related events, then you see how that plays a huge role in aggressive tendencies. Like I mentioned, well, I'll get to it in a little bit. It's more appropriate a little bit later. So when we have this idea of operant conditioning, does anybody in here have a psych background, like a psychology degree for a bachelor? So you've got a huge idea about operant conditioning, probably much more than I have. But operant conditioning, this occurs when a behavior is positively or negatively reinforced. So an idea about negative reinforcement would be you tell somebody to do something, they refuse, and then you reinforce that negative behavior by going ahead and having somebody do that task for the patient or individual anyway. So they refuse, the task gets completed, that negative behavior is reinforced. Positive reinforcement, the task is completed and there's some positive reinforcer behind it. Neurophysiological disorders. So neurophysiology plays a huge role in the development of aggression. There's research still being done, but we know that brain chemicals and neurophysiology does play a huge part in it. So when you're looking at neurophysiology and the development of aggressive tendencies, you know that decreased serotonin plays a huge role in aggressive tendencies, and increased testosterone plays a role. And that decreased serotonin, that's going to increase impulsive tendencies, which kind of makes sense because if you look at your bipolar patients, a lot of the medications to treat bipolar disorder increase serotonin levels, which decreases impulsivity, and then testosterone. A lot of your aggressive tendencies are going to be a lot more common in which gender, males or females. But statistically, they're more common in males, and you have an increased testosterone level in males. And then there's that common adage and belief, steroids increasing testosterone, increasing like that roids rage, aggressive behavior. So there has been evidence to show that brain disorders can increase aggressive tendencies. And you look at the correlation between that and psychiatric mental health nursing, we know that there are obviously neurocognitive aspects that correlate to this. Loss in function of the brain cortex, brain tumors, brain trauma, encephalitis. So a lot of these things that impact the brain are also present in your psychiatric and mental health disorders, in part because they impact brain function. So this is a good example example question to kind of hone in on that would be an example of questions on the test. After repeated requests for a client to unpack and get settled on the psychiatric unit, the client states, I have no intention of unpacking and staying on this unit. To avoid a confrontation, so actively avoiding a confrontation, the nurse unpacks the client's belongings. Which behavior is exemplified? Positive role modeling, negative operant conditioning, assertiveness, or aggressiveness? B. So it's negative operant conditioning, not positive role modeling. And the reason it's negative is because the patient automatically refuses. And so in order just to appease the patient, the nurse unpacks the belongings. And so in that patient's mind, he says, well, I can just say no and get whatever I want because she did it anyway. So now when the nurse asks the patient to do something next time, they'll say, oh, I'm not going to do it because you didn't make me do the last thing. So the more appropriate thing to do would be like, okay, you don't want to unpack? Your clothes will just stay there. You're not going anywhere. I mean, you're here already. So when you want to change clothes and unpack, you'll eventually unpack. You'll do what I said. No. An example of what would have been positive role modeling, if the patient said, okay, I'll unpack my clothes, but I don't know where to put them. I don't know what to do with them. I need help. The nurse said, okay, well, I'll show you what to do. I'll show you how to do it. I'll show you where they go. And you can unpack them. But there's no negative behavior attached to it. So that negative behavior is what's a big key. So with those biochemical factors, obviously, like we said, there's a correlation between aggressive behavior and brain chemicals. Testosterone, like we've said, plays a key role in deficits in serotonin. That's something to take note of. As we've also mentioned, the socioeconomic factors that exist. And then exposure to violence. So that should cue you in, the exposure to violence, because what do a lot of our patients have? A history of what?
Trauma.
Yeah, abuse and trauma. So for example, we had a patient at Norton's, and I mentioned this to my clinical group. Between ages 4 and 8, he'd been raped by his father, and his father's friends had been gang raping him for 4 years. And then he witnessed his sister get raped, his older sister get raped by his father on, I guess, several occasions. And his father had been giving him meth since the age of 4. So, obviously he's had an exposure to that. He was acting out in school, touching his peers inappropriately at 8 years old. Why? Well, he thought that was an expression of, because he said in his, to social workers and to the nurses, my daddy and his friends would play with me. So he thought that's what playing was, being raped. Like he thought that was normal, because that's all that he'd known. So he has obviously a very skewed idea of what affection and friendship and stuff is, because that's just what he knows. So he was conditioned to believe that that's how people play. So when you talk about exposure to certain things, well, he's been exposed to that now for basically all growing up. And so he's obviously going to have tendencies to repeat these types of behaviors. That's what's been modeled to him. When you talk about socioeconomic factors, you know, it exists in Kentucky, in the extreme rural areas of eastern Kentucky, we have a huge Caucasian rural population that's using drugs, heroin, methamphetamine, which we are having to address right now. There's urban areas with high Hispanic and African American populations that are also at huge vulnerable population risk. So as nurses, we have to be advocates for those populations, and nurse policy is trying to address those things. Environmental factors, we know that environment can play a role, and we're always trying to create what type of environment for our patients? A safe environment for our patients. So this would definitely be something that you want to highlight in red pen and take note of. That this can increase risk for aggression related to environment, physical crowding, discomfort in the environment, and increased noise. Again, something to be very aware of is the best predictors of violent behavior. So alcohol or any drug type of substance abuse, history of child abuse, and then a history of violent criminal acts. And so drugs or alcohol intake can be expanded to include cocaine, methamphetamines, amphetamines, bath salts. So just remember it can be any type of drug. And the interesting and nice thing about the way your book breaks things down is it tells you how to take a step back and look at the mental health nursing process using the overall nursing process. And so we know that we want to utilize assessment to gather information about the risk factors. So this would be something like our pre-intervention stage for relationship development. But we know that the best intervention in terms of aggressive behavior is prevention. Because we know that anger is a learned behavior and that a lot of this starts by role modeling early in the relationship. So we want to try and prevent those things from ever happening. That's definitely something to take note of. That the best intervention is prevention. Another thing to note on this slide or to add to it is that in current meta-analysis studies related to psychiatric mental health, 1 in 5 individuals that have had acute inpatient hospitalization related to psych nursing, related to psychiatric mental health, they will go on to create a violent criminal act. So that's why successful treatment is so important, because they have such a high risk for going on to partake in a violent criminal act. And so we want to look at these cluster of characteristics and be able to differentiate these cluster of characteristics related to anger from the characteristics that relate to aggressive tendencies. So obviously there's some overlap, and I would never try and confuse you by picking things that are very, very similar. But if you look at the more demure characteristics, like frowning, just basic yelling, things that are related to like eye contact, low-pitched words, being passive-aggressive, a flushed face, you can tell that those are, more low-level emotions. If you look at aggression, you've got threats, verbal and physical threats, so you're actively threatening to harm someone, threats of homicide or suicide. Panic anxiety leading to misinterpretation of the environment. So you misinterpreted something that could lead to an active, overt physical attack. Disturbed thought processes, destruction of property, acts of physical harm towards another person. So you can easily differentiate between the more serious characteristics on each list. So that would be something to take note of. On this one, you're assessing risk factors. Again, this is very intuitive of the pre-interaction phase. So you're looking at the past history of violence, the client diagnosis, and the current behavior. So what's important when you're in that pre-interaction phase? What have you not done with the patient? You've not met the patient yet. So you're looking at all this past, this assessment data that's available to you basically in the past history illness that they've had. So you can gather all this and get a picture of the client before you go in to meet with them, and you can start thinking about interaction techniques that you can employ. This can help you paint a picture to know if they have really serious personality characteristics. One thing I wanted you to take note of were 3 types of personality disorders that we like to call the sociopath triad, which is antisocial personality disorder, borderline personality disorder, and narcissistic personality disorder. A lot of people think that antisocial personality disorder is being withdrawn into oneself and not liking other people, but it's actually the opposite. Being antisocial is being antisocial, where you don't like other people, but antisocial personality disorder is characterized by somebody that often has a history of a lot of intense criminal run-ins with the law, criminal history. Normally it can be characterized by people that like have tattoos on the face, the neck. They're often very charismatic, but are very violent. Borderline personality disorder, obviously we know, have intense mood swings and are very difficult to deal with from the psychiatric perspective. And then narcissism, have an intense love of themselves and disregard for other individuals' feelings. Yeah.
Sorry, what was the name you gave all three of them?
The sociopath triad, so they're sociopathic, a true sociopath. A great example in history to look at would be like Ted Bundy. He was the individual that slaughtered several people. He was a serial killer. He's most famous for going into a sorority house and killing everybody that was there. A lot of college females. Yet he was very charismatic and very likable. Like there were women still at his court date that were like stalking him outside, wanting to marry him and stuff. Everybody like loved him. He like had this demeanor, I guess, just drew people to him. They're often like that. Like during the day, everyone loves him. At night, he's out doing all sorts of weird stuff. Serial rapists, serial killers, a lot of them are like that. And they're highly, highly aggressive individuals. That's important in the psychiatric mental health setting because they can be very manipulative. Like my Wednesday clinical group, they met the rapist. Well, I call him the rapist. We don't know if he's a rapist, but the rape kit guy that came in with the duct tape and all that kind of stuff. They loved him. Great. So nice. Awesome. Talked to him in group. Everything like that. Was this in this class? Did you guys have him? No, you're not. I'm going to say it's this week. Okay. Yeah, thought he was fine. Yeah, I thought he was great. So,
I saw that on the news.
What?
And if they were twins, the girls. Did you see that on the news? The two girls they found taped
together?
I wasn't sure if you were joshing us or not, and then I really did see it on the news.
Yeah, I told you.
I was like, oh my God.
Don't lie. None of the things I tell you in here are a lie. All this crap happens. That's what's scary.
Like, oh my God.
Yeah, I don't
They were
think
pretty
it was that.
girls too.
I'm not that like. I don't think that fast. Yeah, everything's real. This is my life. So, when you're looking at the prodromal syndrome and behaviors associated with this stage, looking at high levels of anxiety, verbal abuse, profanity. And then, this is when the individual is ramping up. And also often be very demanding, very rigid postures. This is where you want to implement de-escalation techniques. So this would be applicable for your case study, for example. This was a good one. I included this because I'd actually never seen it before whenever I was going through your book. Ineffective coping related to negative role modeling and dysfunctional family system. If you read your case study, there's a lot of family issues that are present in that. This could take the place of like risk for suicide, risk for self-directed or other directed violence. That's a fancier way of saying you're going to harm yourself. So with your outcome identification, of course, we want to implement short and long-term goals that are individualized to whom? Your patient, your specific patient. And if the timelines are realistic and attainable, some of the things that we want to keep our mind on is that the client's able to take responsibility for their own feelings and identify their anger. They don't cause harm to anybody else or themselves. They're able to recognize that they're becoming angry and ask someone for support. And so we know with this planning and implementation that we utilize appropriate interventions for each, and that we have sound rationales. With this cognitive behavioral therapy, it's rooted in evidence-based practice. And we're gonna combine our cognitive behavioral therapy with what? That we learned about at the very beginning of this course. Yeah, medication, psychopharmacology. And then we're gonna constantly educate the patient on why this is important to take medication and continue therapeutic interventions to create sound treatment for their recovery. Because we have to utilize this dual-tiered approach, or even multiple approaches, more than just dual, but in order for it to be successful. So an angry client states to the nurse, which if this is the worst thing that's ever said to me in a psych setting, I would be thrilled, but you red-headed skinny witch, thank you for calling me skinny. You can't tell me what to do, which appropriate nursing intervention, which appropriate intervention would the nurse implement during this outburst? Reprimand the patient, respond to angry expressions with matching verbalizations, offer support to by the use of empathy and therapeutic touch, ignore initial derogatory remarks. Yeah, D. You want to ignore the remarks because you're going to get called all sorts of names, like it's, and you just let it roll off your back. I mean, using empathy is great. If you get close enough to touch the patient, you probably get punched in the face. So just don't ever get close enough to do that. Only touch them if you're going to put them on in a hold or give them a shot or something. Sometimes, and if you're going to hug them, like side hug. Don't ever hug them like front on because they grab you. So just side hug. Be careful with those. So again, lack of feedback often extinguishes the issue. If the patient's saying stuff to you, they're often trying to get under your skin. However, it can be hard when you respond to angry expressions with matching verbalizations. And this is why you have to be careful and keep yourself in check whenever you're, especially in the field of psychiatric nursing, when you're a brand new nurse, you're going to work 1,000,000 hours because you want to make money, and so you can burn yourself out. Because you can make really good money when you first get out of school. If you work hard enough, you can easily make it like into 6 figures, I swear. So you can just like bust it whenever you get out of school. However, you can work so much that you go crazy. I've seen it happen. We had a nurse that worked tons of overtime. She was older nurse, she was seasoned, but she worked so much. The patient was already in restraints, y'all. Had already received shots. This patient was subdued. We won. And the patient said it. She was a little dwarfish. She was kind of like, she had no neck. I don't know. And she had bad plastic surgery. That was another thing. Well, he pointed out all these issues very rapidly and a very good insult. And then he tried to spit on her. He missed. He didn't get her. He missed. So what did she do? She turned around on a swivel, spit on him, called him the N-word, and then gave him the finger. I'm out. I'm out. No joke. Like I said, I don't make anything up. Needless to say, come Monday, there's that come Monday, she did not have a job. She was, nor any references of good standing, she was out the hospital. You can't do that kind of stuff, and she just lost it. Like, she spun out into an oblivion of like, and then she was like, what happened? what happened? Who want pizza? Anyone wanna go and get pizza with me? She like just blanked out for a minute, she just lost it, she didn't know what happened, like they were showing her the playback on the video, she was like, oh God, that's me? Like she just didn't know, like, she literally said she just kinda, I was like, I lost it for a minute, I just lost my mind. So, yeah, people just lose it sometimes. So with evaluation, you wanna make sure that your plan is working and that the client is able to, again, recognize when they have aggressive feelings coming, propping up and coming forward. A big thing is that they're able to take responsibility for their own actions, even if they have an outburst, if they're able to recognize that and be able to process and debrief. Debriefing is big, if they're able to debrief with you about what happened. Talking to staff or seeking out staff for support is huge. And like we said, anger can be what kind of, can be employed to do what? It can be a motivating factor. And so if they realize they're getting angry, if it can be transferred into something that's more constructive, that's excellent. And if they can avoid doing harm to anybody else, and they can utilize a problem-solving approach to minimize frustration, then that shows that they've been making real progress. This is a slide you want to highlight in red pen, because this could be a really good select all that apply. Question, what are some techniques when dealing with aggression? Obviously, you want to try and talk the patient down using what type of communication techniques? Very therapeutic technique, communication techniques. Then emphasize using a rapport and trust that you've developed with the patient. Physical outlets, that's important. You can have it, take the patient to the gym, utilize the expression, the therapy room or exercise room. Medications, my favorite. Call for assistance, call code or stat security response or something. Restraints. The big thing with restraints is if you put the patient, oh, you're leaving, I'm sorry. Just leave my office open. Restraints, if you put the patient in restraints, what do you want to make sure that you do once they go in restraints? Check, you want to assess the patient frequently, and then you want to let them out of restraints when?
As soon as possible.
As soon as possible. With your observation and documentation, what's important about documentation that you guys have already pointed out? I'm sorry? You didn't document it, it didn't what? Didn't happen. Then like I said, staff debriefing. And if you're doing staff debriefing, or you're doing numerous assessments, what do you want to make sure to do? If you debrief with staff, or you've done assessments, you always want to do what after you do them? Document them, very good. You want to document. Anything that you do, you want to document it so it's well noted, and it can be included to revise intervention plans or nursing care plans for the patient. Does anybody have any questions about anger or aggression? Do you see how you can apply this back to therapeutic relationship development and therapeutic communication, and then also how there's numerous legal and ethical perspectives that come into consideration in dealing with aggression? All right, so this is the beginning of exam 2 information. You don't have to know this for exam 1. If you have any questions about anything, feel free to email me.